Clinicians, in fact, welcome appropriately applied interpretative comments on clinical chemistry reports, and thyroid function report comments have been shown to improve patient outcomes. And so we have a duty to add value to reports where appropriate. And comments may be appropriate where management treatment decision is indicated by the results. The result is unexpected. A specific question has been posted, but the answer is not obvious, or a clinician has requested a test with which they are unlikely to be familiar. Interpretation should be provided by an appropriately qualified and trained person. Comments are more appropriate for GPs and junior doctors, but some specialists too in the area which they're not familiar with, and we have to be careful about not over-interpreting the results. Possible components of an interpretive comment include the description of abnormalities, the presence or absence of abnormalities, and the degree of severity, implications of the abnormality, diagnosis, prognosis, change in status, etc., and the suggested follow-up. We need to communicate with clinicians by other means, direct communication and at meetings to discuss protocols and diagnostic criteria, and also discuss unusual cases and take part in clinical meetings. So go on to biotin interference. There was a question at the last meeting. Someone asked, should we have a comment about biotin interference? Yes, absolutely. So I've given here a template, high dose biotin, and I've given a high dose as greater than 5 milligrams per day, may falsely decrease or increase reported serum X or serum Y, depending on what you're reporting, and give the assay details. That's very important. And at the bottom, you can ask for the doctors to contact the laboratory to discuss further details and provide a phone number, ideally a direct number they can contact you on rather than going through the switchboard. But be aware of assay updates. Assays are being continually updated, reformulated to reduce or negate interferences, and I'm aware that biotin interference in some assays are being worked on and reduced or completely negated, so you need to be aware of that. Okay, we'll get on to the results. These are a bit more complex than the last webinar, but starting off with a fairly straightforward set of results in a 30-year-old female. A general practitioner is investigating for amenorrhea. The TSH is reduced and the free T4 is slightly high. Obviously, we want to add free T3 to see what's going on here. Free T3 is at the upper end of normal. So a comment could go like the suppressed TSH and high or high normal free T4 and free T3 suggest hyperthyroidism. TSH receptor antibody, which is shortened to TRAB, may be useful. Be careful of using shortened form in comments. The doctors may or may not understand. I'm using this here because you understand. However, a low TSH may be seen in pregnancy. This is a young woman with amenorrhea, and the possibility of pregnancy should always be considered. These results are in fact within reference intervals for first trimester. So if the patient is pregnant, then these results should be repeated in 6 weeks to see whether this is a transient hyperthyroidism of early pregnancy, which can be caused by a very high HCG, or a real thyrotoxicosis. The question arises, if you suspect the patient may be pregnant, or if you want to exclude pregnancy, can you add on an HCG? Probably not. Laboratories adding on a test is an issue that needs discussion and discretion, especially tests like pregnancy tests. So I would leave it to the doctor, or I would ring up the doctor and ask if they had considered pregnancy and whether HCG should be done. I wouldn't add on an HCG without checking with the doctor. So this is just to show you the first trimester TSH, which is, and these results are within the first trimester reference intervals. Going on to the next case, a 53-year-old female who's come for annual checkup, and the thyroid function tests are given. TSH again suppressed, T4 well within the normal range, and T3 at the upper end of the normal range. And there are a number of clinical conditions which can present like this, such as a non-toxic goiter, subclinical hyperthyroidism. Glucocorticoid therapy can reduce TSH. So again, here we are suggesting a repeat in 6 weeks' time. There are other causes of suppressed TSH. We don't know if the patient is on T4 replacement therapy, so excessive T4 therapy for hypothyroidism can give these results. Alternatively, treated hyperthyroidism. Now, reduced TSH may also be seen in elderly patients or in acute psychiatric illnesses where TSH may be reduced and free T4 may be increased. So just to give possibilities to the doctor to consider, and the clinical details fit, then they can work that out. But we do suggest a repeat in 6 weeks' time, and 6 weeks' time, T3 has clearly increased, and the increased free T3 and suppressed TSH are now consistent with T3 toxicosis. The next patient is an 84-year-old female who presented to the emergency department last week in our hospital. In fact, she had severe hypertension, sweating, and palpitation. So a number of investigations were done, including thyroid function tests, and the TSH was suppressed. Free T4 and free T3 were very high. So the results, the diagnosis is fairly obvious. The severely increased free T4 and suppressed TSH are consistent with thyrotoxicosis, suggest TSH receptor antibody test to confirm or to check for Graves' disease. And this is a circumstance where I would in fact urgently phone thyroid function test results, because these results can in fact explain the presentation of this patient. Alternatively, if the TFTs had been normal, I would consider pheochromocytoma as a possible cause of these these clinical findings if the TFTs were normal, and I would suggest plasma metanephrines to exclude pheochromocytoma. But in fact, these results are clearly indicative of thyrotoxicosis. In fact, this patient was diagnosed with thyroid storm. Thyroid storm is an acutely presenting severe thyrotoxicosis with hypertension or hypotension, sweating, palpitation, and high fever, and it can be an emergency. It often happens with excuse me, acute trauma to the thyroid gland, or during manipulation in surgery, or infection and inflammation of the thyroid gland. In this patient, diagnosis of thyroid storm was made, and given the age of the patient and frailty, in fact, this patient didn't survive. So this is a unusual circumstance, but thyroid storm is an urgent or an emergency situation. Exit of results. This is a 46-year-old female who was recently started on carbimazole therapy for Graves' disease. Carbimazole is an antithyroid medication usually used for treating Graves' disease. And here you see the TSH is suppressed, but the free T4 is in fact low, and obviously due to the action of carbimazole. So how do you interpret these results? The reduced free T4 is consistent with excessive antithyroid treatment. The suppressed TSH may in fact take many months to normalize following commencement of antithyroid treatment. If the TSH has been suppressed with long-standing thyrotoxicosis, it takes a long time for it to unsuppress with treatment. So in the early stages of managing thyrotoxicosis, the antithyroid therapy is in fact guided by the free T4 level and not the TSH level. So you would want to maintain the free T4 in the upper half of the normal range without worrying about the TSH. Once the TSH unsuppresses and normalizes, and then later on in the management of thyrotoxicosis, TSH is used for guiding therapy. Similar principles apply to hypothyroidism as well. Initially, you want to normalize the free T4, and then TSH, once it's normalized, then you want, in the long run, TSH is used for maintaining therapy. So the 57-year-old female with a TSH of 120, every now and then we see this very high TSH in patients with past history of thyroid cancer, usually from nuclear medicine or endocrinologists. And this is a particular situation where patients are given recombinant human TSH to stimulate the thyroid gland prior to iodine 131 therapy, for either to do to ablate the thyroid gland, or just to do a thyroid iodine thyroid scan. Alternatively, for a short period, there is thyroxine withdrawal. So these are patients who are usually on suppressive treatment with thyroxine. Prior to treatment, thyroxine is can be withdrawn and let the TSH increase, because these patients usually have had total thyroidectomy, so TSH goes up very high and then stimulates uptake of iodine. So this is used for either a thyroid scan, uptake scan, or radiotherapy, as well as for measuring thyroglobulin, and I'll come to that. So a 61-year-old female in the oncology clinic with a past history of thyroid cancer, post-thyroidectomy monitoring with thyroglobulin. So they have requested thyroglobulin measurement in this patient for monitoring purposes. So it's a slightly more specialized area. In our hospital, this is usually jointly undertaken by endocrinologists and nuclear physicians. So this patient has a thyroglobulin of 31. What does that mean? I haven't given the reference interval. I'll come to that. So thyroglobulin is a tumor marker for thyroid cancer. Post-thyroidectomy, you would actually want thyroglobulin to be undetectable. Human TSH stimulated thyroglobulin testing is recommended to unmask occult disease in such patients. So as I mentioned, the thyrogen stimulation is used to test for thyroglobulin levels. Alternatively, if we use highly sensitive serum thyroglobulin assay, the TSH stimulation may not be necessary. I don't want to go into detail here. As long as you know the basics, you can read up further. Now, the important thing is antithyroglobulin antibodies, if present, interfere with thyroglobulin immunoassays. So whenever thyroglobulin is measured as a tumor marker, antithyroglobulin antibody should also be measured, because in the presence of antithyroglobulin antibody, thyroglobulin measured by immunoassays are not very reliable. So in this patient, thyroglobulin was raised at 31 and antithyroglobulin antibody is negative, so the results are probably correct. So what we say is in athyrotic patients, so patients whose thyroid gland has been removed by total thyroidectomy, on suppressive thyroxine therapy for differentiated thyroid cancer, thyroglobulin should be less than 0.1. So the detectable level depends on the sensitivity of the assay. The high sensitivity thyroglobulin assay can measure down to 0.1, and that's why this is given here as 0.1. If it's a conventional assay, you would use 1 microgram per liter as the cutoff. And if it's undetectable, then that would suggest minimal risk of recurrent cancer. However, the results should be interpreted in the context of serial measurement. Always, as in other tumor markers, serial measurements are done. And clearly there is detectable thyroglobulin in this patient, and therefore this patient needs to be followed up further. Giving an alternative scenario, I mean, this is not a real case, but if this patient had provided these results where the thyroglobulin is undetectable, but antithyroglobulin antibody was positive, then we would say that positive antithyroglobulin antibodies may interfere with this thyroglobulin immunometric assay and cause a false negative result, making the thyroglobulin result unreliable. Basically, if antithyroglobulin antibody is present, immunometric assays, most of the automated assays are immunometric assays, they are negatively interfered and by the antithyroglobulin antibody, and therefore the results are unreliable. In fact, some people would not even report the negative thyroglobulin results. Alternative assays are now available in some centers. LC-MS assays for thyroglobulin are available, and they are an alternative which are not interfered by antithyroglobulin antibody. So you need to know, if you're measuring by immunoassay, what the sensitivity of the assay is, whether it's a high sensitivity assay or a conventional sensitivity assay, and if it is an immunometric assay, that it will be interfered by antithyroglobulin antibody. So whenever thyroglobulin is measured by an immunoassay, antithyroglobulin antibody should also be measured. Now, RIAs are also available, previously used, and they are less interfered by the antithyroglobulin antibody, but some interference is possible, and in fact, positive interference may also be present in RIA if antithyroglobulin antibody is present. So basically, whenever you measure thyroglobulin by immunoassay, you have to measure antithyroglobulin antibody, and the results should be interpreted appropriately. Usually, the specialists are aware of all these, and you would expect these patients to be managed by specialists, but generalists may not be, and therefore you need to be able to provide appropriate interpretation and further advice. Another point to make is that the antithyroglobulin antibody itself may be used as a surrogate tumor marker. So in a patient where thyroglobulin is negative, but antithyroglobulin antibody is positive, that can be followed up. And if the treatment is successful, antithyroglobulin antibody should gradually decrease over the years. they say it takes about 3 years for it to disappear. If it doesn't disappear, or in fact if it increases, then that is used as a surrogate tumor marker, suggesting that the tumor, that thyroid cancer, is present and possibly recurring or increasing in size. Next patient, 50-year-old male, was tested with thyroid function tests because of a family history of thyroid disease. The TSH is just above the upper limit of normal, T4 clearly normal towards the lower end, but the free T3 is at the upper end of normal. TPO antibody is positive. TPO antibody is a marker of thyroid autoimmunity. It's the first line autoimmune marker for Hashimoto's thyroiditis, but can also be raised in Graves' disease. So what we tell our doctors is that free T3 measurement is really only helpful in hyperthyroidism. This set of results, free T4 and TSH by themselves, together with the TPO, really suggests subclinical hyperthyroidism due to Hashimoto's. The free T3 is at the upper end, maybe slightly above the upper end, but it's really not helpful in this case. And we sometimes see a free T3 which is not helpful. And in fact, the free T3 should never have been measured. The first line of testing is TSH and or TSH plus free T4. And the free T3 should really be added only to confirm hyperthyroidism. And in this case, it shouldn't have been done, and it really is causing confusion. Except one situation where you can see a raised free T3 with a low free T4 with either a normal TSH or a TSH around the normal range, as in this case, is where the patient is in fact being treated with free T3 replacement, where the free T3 might suppress TSH or normalize TSH, but the free T4 would be low. But we need to know if the patient is on free T3, and there's no indication that this patient is on free T3. It's more likely that the patient has got subclinical hyperthyroidism. Next patient is a 62-year-old male. Again, in general practice, and the request form says patient is on amiodarone. Amiodarone has major effects on the thyroid gland, and you need to be aware of those effects. In this case, TSH is clearly suppressed, free T4 is clearly raised, the free T3 is within the reference interval or at towards the upper end of the reference interval. So here, because the patient is being looked after by a general practitioner, we would want to advise them. So how much you say in the comment is a matter of judgment. You want to keep it short but useful. And in this case, a suggested comment is something like amiodarone inhibits T4 to T3 conversion, as well as presenting the thyroid with a large iodine load, which can have a number of effects. The suppressed TSH and raised free T4 may suggest amiodarone-induced hyperthyroidism, but the results should be interpreted in the light of clinical findings, whether the patient is in fact clinically hyperthyroid. Amiodarone can cause hyperthyroidism. There's the type 1 and type 2 hyperthyroidism. You should read up on them, or it can cause hypothyroidism due to the high iodine dose. So a number of effects, and it's not something you can summarize in the comment. if the doctor wants to discuss, you can certainly discuss with the doctor. And that's if you provide your contact number, and that's something that you can consider doing on all your reports. If they want to then ring you and discuss, they can do so. Alternatively, you could suggest referral to an endocrine specialist, and that's something that you can do if you think the doctor will take kindly to that, and especially if you think this is something that's beyond the doctor's, this particular doctor's area of expertise. Next patient, 51-year-old male with a history of diabetes, the TSH, which is well within the normal range, and the free T4, which is clearly raised. So a comment we often use is that a normal TSH indicates an euthyroid state. Causes of a raised free T4 with reduced T4 to T3 conversion include non-thyroidal illness, certain drugs, and of course treated thyroid disease. If this patient is on T4 replacement for hypothyroidism, these results indicate adequate replacement because the TSH is within the normal range. Of course, you would want to do the T3, free T3, if the patient is not on treatment. If the patient is on free T4 replacement, we can stop with that. But free T3 would be useful. And here the free T3 has been done and it's raised. So what do you do next? So we need to exclude heterophile antibody causing a falsely elevated TSH. So if the patient is thyrotoxic, the TSH would be suppressed, and heterophile antibody can in fact falsely increase TSH. Alternatively, the free T4 and free T3 may be falsely increased due to thyroid binding globulin abnormalities. I don't want to go into the detail, but again, that's something to consider. So when we provide the doctors with the results, we should exclude all these before we provide the results. So here we say the results confirmed by an alternative method and heterophile antibody excluded for TSH. If you've done further studies to exclude falsely raised free T4 and free T3, again, you can mention that. Obviously, you can't dilute samples for free T4, free hormone measurements. That completely mucks up the assay. So you have to do alternative measurements to check for the results. So once these are confirmed, then there are two options. Consider specialist endocrine referral to test for TSH secreting tumor. So with TSH secreting tumor, you can have a normal TSH with raised free T4 and free T3, or a raised TSH. Most often TSH is in fact within the normal range with a raised free T4 and T3. Alternatively, a TSH secreting tumor, thyroid hormone resistance. So that's a genetic condition where the patient's the T4 receptor is resistance due to genetic abnormality, and they therefore secrete higher amounts of free T4 and free T3. This patient 3 years ago had a clearly normal free T4 and TSH, which gives you a clue to what this patient hasn't got, and that is that the patient hasn't got a genetic condition. So it's unlikely to be thyroid hormone resistance, which is a genetic condition. So here we are saying previous normal TFTs noted, making thyroid hormone resistance less likely. Consider specialist endocrine referral to investigate for TSH secreting tumor. Another test which can help to ascertain if the patient has a TSH secreting tumor is an alpha subunit measurement, which may be raised in the presence of a TSH secreting tumor, because alpha subunit is also secreted by pituitary, and in the presence of a pituitary tumor, alpha subunit is increased. That would be considered a fairly specialized test, so you would really want an endocrine referral. So there are further tests to so dynamic function tests, TRH stimulation tests, etc., which I won't go into today, can be considered an alternative webinar. But at this stage, this patient really needs to be referred to a specialist. Next patient, a 39-year-old male presenting to the emergency department with general weakness, fairly severe general weakness. The TSH is clearly suppressed, free T4 and free T3 are clearly raised. So yeah, these results suggest hyperthyroidism. Sometimes other results might help in making a firm diagnosis. In fact, you should always consider looking at all the other results when making a diagnosis. And in this case, the electrolytes showed fairly significant hyperkalemia, and the clinical details says this is an Asian male, and that's important in this clinical setting. You probably have guessed the condition. Thyrotoxicosis with hyperkalemia and muscle weakness may be consistent with thyrotoxic periodic paralysis, which is common in young Asian males. So that's a diagnosis you have made by looking at the electrolytes as well as the clinical presentation. And the TRAB TSH receptor antibody was positive, confirming grades course of the thyrotoxicosis. Next patient, a 51-year-old male presenting to the general practitioner with a history of previously raised TSH. In this case, the TSH is 4.5 and free T4 is 8. Now, the relationship between free T4 and TSH is a log relationship. So when T4 goes down, TSH goes up much higher. So normally TSH is raised before T4 goes below the reference interval, and by the time free T4 is below the reference interval, TSH is a lot above 10 in hypothyroidism, whereas in this case the free T4 is low, but the TSH is only marginally raised. So what does it mean? The presence of a low T4 with only a marginal increase in TSH may suggest pituitary insufficiency, although these results may also be seen in non-thyroid illness. So you need to consider subclinical, you need to consider non-thyroid illness. So if you're thinking of pituitary investigations, it might be worth retesting to make sure these abnormalities are persistent and not due to acute illness, and specialist referral for secondary hypothyroidism. So this is another patient who is on T4 replacement for pituitary failure, and these results show a very low TSH and a free T4, which is 8. The comment here is free T4 should be maintained in the upper reference interval in patients on thyroxine for secondary hypothyroidism. We don't use TSH in monitoring pituitary failure patients or secondary hypothyroidism, so we only use free T4. I've got just a couple more cases. Here's a 66-year-old female presenting to the emergency department, semi-comatose. Electrolytes show severe hyponatremia with hypokalemia. The other abnormalities of note, a CK of 888 and a very high cholesterol in an acutely ill patient. Of course, there could be a number of possibilities, but this being a thyroid webinar, we want to check the thyroid function test, this pattern of abnormalities, hyponatremia, hypercholesterolemia, and a raised CK due to myopathy may be seen in severe hypothyroidism. So just measure thyroid function tests. This patient had severe hypothyroidism. The diagnosis of myxedema coma was confirmed. So finally, before I finish, I just wanted to point to a paper on thyroid function analysis in 50 patients with COVID-19. I have to say something about COVID, given the current situation we're all facing. This is a retrospective study performed in China on 50 patients with COVID-19 without thyroid disorders. So these are patients with COVID-19 illness, but without thyroid disorders. Now, so they looked at thyroid function test results in patients with COVID-19 who were admitted to hospital, compared them with normal healthy people and with non-COVID patients with significant respiratory illness, pneumonia. And really what I wanted to show is the TSH. In this study, they have measured total T3 and total T4, which we don't do in most situations. What's interesting is that the TSH is clearly low, which you see in non-thyroid illness, but when you compare the TSH with non-COVID patients of similar severity, the TSH is a lot lower. Total T4 is similar in all three groups, whereas total T3 is lower in the COVID and the non-COVID sick patients. Now that's not what we measure. Free T4, in fact, is lower in sick patients due to albumin abnormalities, etc. So I won't go into that. And the severity of the illness is also related to the TSH levels. In critically ill patients, TSH, in fact, decreases very significantly in COVID-19. And all these patients, in fact, recovered to normal thyroid function test when they recovered from their illness. So it's a transient change in thyroid function tests in COVID-19, which is more apparent than in patients of similar severity of other illnesses. I'm sure we will get more information on thyroid function test abnormalities in COVID-19 in the future, but this is something to keep in mind in the meantime. So I will stop with that. We've only got about 5 minutes left, but I'm happy to stay on and answer questions. So over to you.
Thank you so much, Dr. Sam. We've already had some questions coming into the chat group. Basically, there's one question here by Dr. Vivek. How to provide interpretive comments in patients either pregnant or non-pregnant where thyroid function test is normal but anti-TPO antibody is high?
Yeah, so if TPO antibody is high and the thyroid function tests are normal, these are patients, euthyroid patients with autoimmune thyroiditis. There is really no evidence that these patients benefit from T4 replacement if their thyroid function tests are within the pregnancy reference intervals. So these are euthyroid patients with autoimmune thyroid disease, probably Hashimoto's thyroiditis, but in the early stages, if their thyroid function tests are normal, you say they are euthyroid, they don't need treatment at this stage, but they certainly need monitoring. So that's what you would say, that to suggest repeat measurements in maybe 6 weeks time, so in each trimester of pregnancy, just to make sure that the patient doesn't develop overt hyperthyroidism, especially during the pregnancy, but even afterwards.
So even for non-pregnant patients, you would still suggest in the comment to monitor the test?
So in non-pregnant patients, we normally say if the TPO antibodies are raised with a normal thyroid function, we would say repeat in 1 year's time, especially if the thyroid function tests are normal. If they got subclinical hypothyroidism with a raised TPO antibody, again, in non-pregnant women, we would say repeat in 6 to 12 months, and a subgroup will develop overt hypothyroidism.
Okay, so for non-pregnant patients, repeat in 6 to 12 months. For pregnant patients, then slightly more often.
Oh yes, yeah, during their pregnancy.
Okay, great. So the next question we have is, hi Prof, how frequently do we monitor thyroid function tests on patients admitted for thyroid storm and myxedema coma?
Myxedema coma.
Yes.
Yeah. So thyroid storm is acute emergency, and they got vascular issues. Their blood pressure is monitored. I mean, they are really managed in a intensive care setting. So the antithyroid treatment takes time to work. They really need to be managed clinically. Their blood pressure normalized, and they would be given beta blockers to reduce their heart rate. They're usually tachycardic, so they're given beta blockers, and then depending on their blood pressure and other clinical findings, they are really managed clinically. Of course, they would be treated with antithyroid treatment, but that takes time. Similarly, with myxedema coma, they would be started on T4 replacement. But again, they need to be managed clinically as well, so the sodium is very low, and that's usually due to water overload, so they would be fluid restricted. The T4 replacement, depending on the patient's age, has to be done slowly because the sudden increase in T4 in an elderly patient can cause cardiovascular problems. But T4 replacement would lead to quite dramatic improvements in their clinical condition.
Okay, thank you. So I just wanted to be aware that we are now at 5 o'clock. So we still have a few questions. I don't know, Dr. Sam, if you have the time now to answer them.
Yes.
Yes. Okay.
Yes.
So we'll keep going to get through some of our questions, and but the session will be recorded, and any question that we don't get to, we'll try to have Dr. Sam answer by email later. Okay. So our next question is, how can one set the reference range for thyroid function tests if we are setting up a new setup? So I assume this means a new assay or new system.
Yeah. Well, this is very similar for any chemistry test. It needs to be appropriate for the population. So I don't think there is anything different with thyroid function tests. We may not have the resources to set up proper thyroid function tests, but we can use a small population, appropriately selected population, to verify our reference intervals. Generally, the rule of thumb is you need 120 subjects to set up reference intervals, but then there are age and other factors. But with thyroid function tests, we generally quote the same reference intervals for males and females. Certainly for pregnant women, that's a very different numbers, and similarly for children. So when a child is born, the TSH is quite high, and then within the next few days it decreases, but TSH is clearly raised in the early stages of life. So it may not be possible or practical to set up reference intervals for children and neonates in early life. You might have to use literature-based reference intervals, but for an adult population, certainly using about 120 patients and the reference and the assay that you're using. TSH has diurnal variation. TSH goes up towards the end of the day, and midnight TSH is significantly higher than in the morning. So ideally it should be done in the morning. So, there are other issues like thyroid binding globulin may be increased in certain situations, especially oral contraceptive pill, and so those are things that need to be considered in setting up reference intervals.
Thank you for that. So, so to set up, naturally, we need 120 subjects as suggested by the CLIA guidelines, and then for just verification of manufacturer ranges, would you suggest then something like 20 patients?
Yeah. I cannot give you exact numbers off the top of my head, but yes, right. 20, 30 or 40, yeah.
Right. Okay, great. So interesting comment about anti-TG that you made, because the next question is how often do thyroid cancer patients have anti-TG?
So anti-thyroglobulin antibody should be done every time the thyroglobulin is measured, and usually monitoring is done every 6 months, so they should be done every time, if that's the question. Alternatively, if you're asking about the prevalence, yes. Antithyroglobulin antibody is the prevalence of antithyroglobulin antibody is about 25% in the thyroid cancer population, which is much higher than in the normal population. So it's about 20 to 30% prevalence. So it's quite high in the thyroid cancer population. So in those patients, thyroglobulin measurement by immunoassay, immunometric assays can be problematic. Yeah.
Thank you. Okay, the next question is how practical is it to calculate free T3 to free T4 ratio and provide comments based on that result to diagnose thyrotoxicosis or Graves?
Yes, we don't calculate them, but we make a mental calculation. When we look at results, over time we develop an eye for pattern, and pattern recognition is important in clinical chemistry because we usually see a profile. And when you see a subject with a suppressed TSH with a slightly raised free T4 and a very high free T3, you usually think of intrinsic thyroid disease, as opposed to a very high free T4 with a not so high free T3, which suggests that the patient is in fact on free T4 replacement. The ratio varies, and also depending on the severity of the disease as well. But we use that more as a guide. I certainly don't calculate the ratio, but if you are able to, and if you've got some cutoffs, then perhaps that's something you can use. I certainly look at the ratio just as a guide rather than calculate it and use cutoffs.
Okay. Next one is does hyperthyroidism increase in urinary tract infection?
No, not to my knowledge. I'm not aware of that relationship now.
All right, let's see. The next one is hi Professor, how much decrement of free T4 is expected after starting antithyroid in 1 day? What is the interval to repeat free T4 alone?
Right, yeah. We generally say 4 weeks, 3 to 4 weeks. The free T4 does decrease fairly quickly. Generally, we don't recommend repeating thyroid function tests within 3 to 4 weeks. TSH might take months to normalize here.
Okay, so the recommended interval is 3 to 4 weeks at least.
Yes.
Another question, does hyponatremia affect thyroid function tests?
No, it's the other way around. The thyroid function tests, hypothyroidism cause hyponatremia due to water retention, as you probably know. I'm not aware of the other, that there is an effect in the other direction.
Okay, great. Another antibody prevalence question, which I assume the question is, how common is heterophilic antibody testing for TSH? I assume they're asking how common are heterophilic antibodies against TSH.
Yeah, I can't give you a figure off the top of my head. It depends on the assay. Some assays are affected more than the others, and it also depends on the population. There is a suggestion that it may be increased in rural population because they are all people who are exposed to animals. Yeah, I don't want to give a figure not knowing the numbers, but it's not common heterophile antibody, especially these days, because assays have been reformulated to with blockers to neutralize heterophile antibodies. They are still present, but not as common these days because the assays have been improved. Yeah.
Yes, definitely. I think from the manufacturer standpoint, we try to do a lot to reduce the interference from this. Okay, we have a question about pregnancy. Dr. Ken says, thank you for a great talk. Do you recommend testing thyroid antibodies in pregnancy? Is there harmonization for pregnancy-related thyroid function test reference intervals?
Is there harmonization? It depends which country you're looking at. Even within Australia, there is certainly within Australia there is a move towards harmonization, and certainly it would be useful. I'm not sure if that has been achieved or not. I'm not aware of the guideline for TPO antibody testing in pregnancy in the absence of thyroid function test abnormalities. We generally only do a TSH or sometimes TSH and T4 in pregnancy. That's what I see from our doctors. In the absence of thyroid function abnormalities, TPO is generally not requested in our practice.
So then, in terms of when would we recommend testing? So thyroid antibodies are not recommended to be routinely tested unless there's a.
So if the TSH is raised, then you would measure.
Understand. Okay, great. So I think we'll just take one last question and wrap this up. How useful is anti-thyroglobulin for investigation of thyroid autoimmunity, or should it be reserved only for TG monitoring? Yeah,
the recommendation is only for TG monitoring. thyroglobulin antibodies are less sensitive than TPO antibodies for Hashimoto's, and they're less sensitive than, a lot less sensitive than TSH receptor antibody for Graves. So it's really not useful in autoimmune thyroid disease. It's really only used in thyroglobulin monitoring, really, to see if there's interference in thyroglobulin measurement. So this webinar is recorded and will be made available on the APFCB website together with the slides. I have in fact provided the slides for the previous webinar. It will be available on the APFCB website together with the recording of both webinars in due course. It should be available in the next few days, in fact. So feel free to use them. Yeah, feel free to contact us if you've got further comments or questions. In fact, Perlene is going to do a survey and give us some feedback on what you would like us to do in future. Thank you for participating.